I'm Ron Hoxworth, Assistant Professor and Director of the Abdominal Wall Reconstruction Program in the Department of Plastic Surgery at UT Southwestern Medical Center in Dallas, Texas. This article is particularly relevant in that over the past 5 years, the field of abdominal wall reconstruction has grown tremendously. Due in large part to improvements in overall techniques for repair, patients previously not amenable to reconstruction are now presenting for surgery. These patients typically have significant medical comorbidities, placing them at increased risks for perioperative complications. Pulmonary complications certainly represent one area of particular interest for any surgeon treating these patients. Data in the past has shown that ventral hernia patients who develop respiratory failure and require mechanical ventilation may have as much as a 4 times higher rate of hospital stay as well as an 18 times higher rate of overall mortality. These numbers are quite alarming. The goal of the current publication is to identify those risk factors predictive of complications in order to improve both patient safety and outcomes while also decreasing the overall burden on the healthcare delivery system. In the article, the authors examine both the rate of pulmonary complications as well as those risk factors predictive of complications. A total of 60 patients were identified over a 2-year period as having undergone abdominal wall reconstruction. There was a 20% rate of pulmonary complications. Of those 12 patients identified, 8 required postoperative reintubation, 4 required transfer to a higher level of care. On average, these events occurred on postoperative day number 3. Further examination of the patient demographics revealed that there were some factors associated with these events. These included a higher ASA classification, an increased patient age, a larger overall hernia defect size, an increase in intraoperative pulmonary pressures. Surprisingly, demographics such as COPD, BMI, diabetes, length of surgery, number of prior surgeries, history of smoking, and intraoperative contamination were not found to have a statistically significant effect on pulmonary complications. On further analysis of the data, the authors provide specific details related to intraoperative pulmonary pressure monitoring. They explain the difference between peak inspiratory pressure and plateau pressures and how each correlates with a decrease in pulmonary compliance. The typical thought being that abdominal wall reconstruction decreases pulmonary compliance and as a result increases the predisposition for respiratory complications. While increases in both peak inspiratory pressure and plateau pressures are both predictive of respiratory complications, the authors in this study contend that it is the plateau pressure increase which most strongly correlates with the development of respiratory complications. They point out an almost linear relationship between the increase in plateau pressures and the development of respiratory complications. An increase in plateau pressure by a value of 6 is associated with a 9 times higher rate of respiratory complications, while an increase of 9 is associated with a 12-fold higher rate of respiratory complications. In order to correlate these findings, a comparison was performed with those patients who remained intubated postoperatively. It was found that peak plateau pressures for these patients decreased over the course of the first 24 hours after surgery. As a result, the authors have now instituted a new treatment algorithm for their abdominal wall reconstruction patients. Any patient with an increased plateau pressure of greater than 6 remains intubated immediately postoperatively. The assumption is that pulmonary compliance will increase gradually in the first 24 hours after the immediate abdominal wall closure. This increased compliance will result in more successful extubation and a decreased rate of respiratory complications. It will be interesting to see how this new treatment algorithm may result in an overall decrease in pulmonary complications for this patient population. In conclusion, I would like to commend the authors from Case University Hospitals on their significant contribution to the literature. Its relevance becomes especially clear when we realize how much the business of medicine is increasing the scrutiny placed upon physicians. It is imperative that we practice not only in an evidence-based but also in a fiscally sound fashion to ensure that our patients receive the best and most appropriate care possible. The findings presented in the current manuscript represent a significant step in that direction.